right. So, what are we going to be speaking about today, and what is my promise to each of you? Well, at the end of this 60 minutes, you will know things about mental health effects of political conflicts that you do not know now. And you will be able to better detect and even prevent certain mental illnesses during these difficult times that we are facing now. So just to mention that I don't have any relevant financial relationships and I won't be discussing any use of drugs or products. What are the objectives of today's talk? Well, we really want to know what is this uncertainty that we keep on hearing from people and how does it affect our mental health and of those around us. Next, we will identify common clinical presentations during conflicts. And finally, we'll be applying strategies to address patients to, as we said, detect and prevent certain mental illnesses among certain people, but perhaps even helping those around us and ourselves. So, just a brief background. How did the field of psychiatry first start to be involved in wars from a medical point of view? Well, it started in World War One and later in World War Two, when they started to notice that soldiers were developing feelings of dread, helplessness, fear, panic, and what is known as mutism, which is basically that they're not talking and they're not responding to others when they speak to them. In addition, they used to also have nightmares, tremors, shaking, emotional numbness, and very weird sensitivity to noises. This is just basically an example of a veteran after he returned from war. And you see how he's just busy with himself in a strange way. And then there's another guy who is very fearful from a very minor stimuli, like this colleague of him raising this hat at him. So, and then it was better described by a lieutenant who was describing his colleague, Lewis. And he said that when they were fighting the Germans, he saw that Lewis was so nervous, he could not sit still. And then a shell has landed near them, and Lewis went entirely to pieces. He fell on the floor. He tried to dig in the floor with his hands, went entirely limp, and they were unable to rouse him or get him to speak, although the eyes were open, and he was apparently not hurt physically, that is. So eventually they had to send him back on a stretcher. And because these kind of events used to happen after bombs were dropped or what they used to call shells, they initially called it shell shock. And then they said, you know what, it may be just related to soldiers and war. So they called it war neurosis. And then military psychiatrists got involved because, they need these soldiers. And they developed what is called an electric shock therapy. And it was used by both parties during the war. So Austrians, Germans, the UK. And the idea behind it was that they would inflict severe physical pain through these shocks to certain areas that were affected. So, for example, if they were mute, they wouldn't speak, they would electrify them in, inside their mouths. Sometimes even their genitals were electrified in order to make them forget their fear and stand back and go to, fight the war. Then they realized and they started to see that, even, okay, but let me just take a step back actually. So why did they used to do that? They used to think that this is voluntary. The people, the soldiers are just scared and they don't want to go to the war. So let's give them so much pain to make it easier for them to go back rather than suffer with us. But eventually they started to see, even after the wars were done, years later, these effects still persisted. So there's no war for a person to run away from. So they started to study it more as a phenomena, as a disorder, as the war neurosis or the shell shock. But then they they studied it further and they realized that these symptoms were even present in people who were not exposed to wars. So, but the common thing was that they were suffering from a previous trauma. So people who are not combatants or soldiers. And they, by the 1970s, they developed what's called PTSD, post-traumatic stress disorder. So what is this post-traumatic stress disorder? Well, this is the criteria in short by the DSM-5, which is the Diagnostic Statistical Manual that many psychiatrists in the world use to diagnose mental disorders. And obviously, I won't go over this in detail because the goal from the talk is not to learn how to diagnose specific mental disorders specifically, but to be able to recognize the signs of distress to hopefully better be able to help everyone cope. So, but the important thing about this slide is that in addition to these symptoms that we mentioned briefly before, these symptoms need to go for a specific period depending on the disorder. So for PTSD, over 1 month. And very importantly, there needs to be functional impairment. So either they lose their relationships or, it's quite difficult for them, or for example, they're not able to perform their duties. In a nutshell, having the symptoms alone without a significant effect on one's life does not mean that one has the disorder. Why is this important? Because a lot of the research that we're going to be talking about shortly mentions PTSD, but mentions or studies PTS or post-traumatic stress, which are simply the symptoms without the diagnosed disorder. And then similarly, stress is not the same as anxiety disorders or major depressive disorder. So when we are stressed, especially during conflicts, one may be scared or worried. They're not necessarily suffering from an anxiety disorder. They may become really sad, not necessarily depressed as in terms of having a major depressive disorder. Okay, now taking us back from the World War I and II to the current landscape, what has changed in terms of war and their effects? Well, 90% of the casualties in previous wars used to be military personnel. Currently, 90% are civilians. And with technology in warfare, and AI and drones and planes without pilots, this number of civilians is projected to increase, and less soldiers are projected to be active participants. And what are we starting to see? Well, the prevalence of PTSD among civilians affected by wars ranges from 9 to 60%, of course, depending on the severity of the war and the geopolitical crisis that is there. And you compare that to about 4% worldwide lifetime prevalence of PTSD. What about depression? Well, 16 to 68% among those affected by wars who are civilians, in relation to about 7 to 10% in other places in the world. Anxiety disorders, similarly, we see about double the percentage in people who are affected by wars. In addition to, of course, other conditions that can be worsened during wars among civilians, alcohol, drug abuse. Okay, now does it stop at the war zones? Do these negative effects of conflicts only happen to people within active combat zones? Well, in this study, this is what they wanted to test. And what they did is that they brought a group of 410 Australian women and they separated them into three groups. So a group were Australian born with no relation to the Middle East in terms of origin, and another group who are women who immigrated either themselves many years ago or they were born to people who were immigrants from the Middle East, specifically Lebanon, Gaza, and other regions of Palestine. And the third group are immigrants, but who are not related to the Middle East. And they interviewed all of these women before the October 7th attack and then after the October 7th attack. And what they saw was that for quality of life, we can see here in blue the women from the Middle East origins. They had a higher score on this estimated quality of life score. And basically, a higher score means lower quality of life in relation to these two other groups. Now, is it only PTSD? Is it only anxiety disorder? No, even panic disorder was seen to have increased among those women from before the October 7th to after October 7th. We can see here the blue, there's a higher incidence of panic disorder, not only panic attacks, which are isolated. All right. Now, people may say, what's the reason for that? Is it that these women just came, from these Middle Eastern countries, or did they observe wars? They found in this study that even women who have never been exposed to wars, but simply came from these regions to parents who were exposed to wars, this had affected them. And let's just sit for a second and think about these transgenerational effects that can happen. All right. So why did I speak about the effects on conflict zones and compare it to outside of conflict zones? Well, because of the peculiarity of the situation that we are facing now. So we have during this war different perspectives of experiences. So certain countries had a direct involvement, Iran, Lebanon. Other countries, like countries in the GCC, including Qatar and Jordan, they were attacked, but they are not really in an official war status. So just a local timeline of the experiences from the talks and the discussions that we've been having with people in the community, with our colleagues, and from what we've been seeing in the clinics was that it started with a fear of death. So people were scared that they will die in the beginning or their loved ones would be killed. And then it started to be, well, am I going to be losing my job? Am I going to be allowed to come back if I leave now to protect myself and my family? And later on, with the talks and the ceasefires that were announced, people started to develop other kinds of fears, like what are the economic effects of the war? Will I be laid off in the future? And then, of course, ceasefires broke, uh, talks and negotiations swindled. So then these feelings kept on oscillating, and people started to report more and more uncertainty. I don't know what's going to happen. So again, this is just showing some of the quotes that I've been hearing a lot. So in the beginning, will we be killed? And then, will there be any economical layoffs towards the ceasefire negotiations and cooling down? And then, of course, I really don't know what will happen because things just kept on changing. So what's the perceived remedy to uncertainty that many of us got into? Well, I don't know what will happen, but I need to know what will happen in order to prepare myself. So you know what? Let me watch the news to try to relieve the uncertainty. But now, I'm worried more. I'm anxious. I'm tired. I'm sad. I'm depressed. And this is when we start to see symptoms of anxiety and depression start to take over. And this is where certain people can tip off to a disorder state. Okay, so what are the effects of rumors in the midst of all of this? Well, we are fortunate with having social media these days, but also we started to see that social media has really played a huge part in how people are starting to think and feel about these wars. So obviously, social media and news networks, they have both rational and irrational discourse. Now, people interact more with the discourse that engages them emotionally. And what do companies want? They want more engagement to get more advertisements so that they can make more profits. Now, the algorithms in these new social media technologies became really good at tailoring themselves to promote things that will engage us more, even if these things are not true. And of course, when we keep on seeing things, even if they're not true, it makes it harder to distinguish what's correct from what's not correct. So then also, people innately have a tendency to believe negative information easier. So as a net result, more negative information appears to us, and we're more likely to believe this negative information. Now let's just sit for a second and think. Individually, yes, there is a mental health toll, anxiety and depression. But also, we shouldn't forget about a concept that's called the emotional contagion, where we've known for a long time through the science of psychology that people's emotions can be really felt by others and even transferred to them. So someone who's anxious or sad, just sitting next to them can get some of these feelings to you as a person. So then it's a risk for collective anxiety as a social mental health job. So studies have shown that, disaster media coverage is associated with PTSD, post-traumatic stress symptoms, depression, anxiety, and substance use. So this is all scientific. Okay. Can we um, can we solve this first question? Uh, so after a bombing attack, who is more likely to suffer from acute stress? Is it people that had relatives that were injured? Is it those who watch the news 1 hour a day, 6 hours a day or more? Or is it the people who actually witnessed bombing attacks? What do you think? Maybe you'll give a minute. Okay, do you think should give more time or have the results? Okay, so these are the results. So as expected and as you know, naturally expected, about 53% of people chose the fourth option, which is those who witnessed the bombing would, probably are more likely to suffer from acute stress symptoms. And then those who have relatives that were injured. This is the second most commonly answered question. And then the third one was about the more than 6 hours a day. Well, let's look into that. So, this is a picture from the Boston Marathon bombing, which is a terrorist attack that happened after September 11th. So it was the first one that happened after September 11th, and it was in 2013. And people wanted, I mean, the scientific researchers wanted to test this specific question. So, yes, the prevailing assumption is that directly exposed people are at greatest risk for developing stress-related disorders. Or you know what, are they? So they assessed more than 4,600 adults for stress symptoms right after this Boston Marathon bombing. And their hypothesis was, the media exposure would have a higher impact than that of direct exposure on development of acute stress. And they define direct exposure as, either physically being there, witnessing it yourselves, or having relatives or people you know firsthand that were either injured or killed during the bombing. And what they did is that for all of these people who they tested, they saw obviously that the more they spent in terms of time on watching bombing related media, so here we see the number of hours, the more they had more acute stress symptoms. But a very interesting thing that they found was that the people who were watching the media for 6 or more hours, and the media was related to the Boston bombing. So in other states that are not in the vicinity of Boston, Massachusetts, they found that those people had more stress symptoms acutely than the ones that were directly exposed. And this was, really fascinating. And the initial assumption would be, you know what, maybe these people uh, who were not directly exposed to the bombings, maybe they had previous mental health issues, and that's why, they wanted to watch the media more often, and hence these are the results. But in reality, even when they controlled for previous history of mental health from their records, the same results withstood. So yes, it's actually for at least during this bombing, it's actually people who watched the news for 6 hours or more per day. And this tells you, the importance of media and how it can affect us and time spent on media. So just a brief clinical scenario of a young man in his 20s with autism spectrum disorder. He has no other mental health history. He used to be, really quiet, pleasant and stable for many years of his life, who presented with acute insomnia and irritability for the past 2 weeks to our clinics. And when we dug into his background, we saw that this person, had withstood the war in Gaza. He witnessed bombing uh, directly, and where he had a severe physical injury. 16 of his immediate family members were killed at the time, and he was brought into Qatar in order to continue treating these severe physical injuries that he had. And during his time in Qatar and during the trip, he was really stable. And this was like more than a year. But just when the war started and the anxieties of people around him, especially his caregivers, started to increase, he got tipped off. And this is, just something that was fascinating to us because it tells you about we don't know what can tip some people off. Sometimes things that we consider minor could actually be major. Now, does this happen only with the war survivors that, they get tipped off into these states? Does it happen only with people with special needs? Because we know that they are more likely to be affected by such situations and geopolitical conflicts. Well, no, we are seeing changes among those without a history of mental health illnesses. We're seeing it with those without special needs or even previous war exposure. And the scientific literature really tells us that the most vulnerable populations, people in the military, children, women, healthcare practitioners, individuals in detention facilities. And this is really important for those of us that work in healthcare. When we have people that come from the prisons and the jails, they have very different kind of social support and limitations to their freedoms, which affect, their stress levels during this kind of period. That is quite different that I imagine to many of us. And of course, previous history of mental illness makes one more vulnerable. Again, just further study that tested this, but they also found that older age increases the risk rather than being younger. They found out that, and when I mean younger, I meant like among adults. Children are more prone, but also being older makes you more prone rather than being a young adult. Lower income, being unmarried is a risk factor, and significant medical history rather than only a psychiatric history also increases the risk. And now, when let's look a bit at children and let's see, how come is it that children are more vulnerable to these kind of stressors, and why do some children develop uh, uh, sorry, develop these kind of symptoms while others are really resilient and don't develop anything, and actually become more resilient and strong when they grow up into adults? Well, they wanted to test this in this group of studies. And they found that family variables rather than the child's variables are what's important. So TV viewing practices of the parents, the reactions of the parents really affect how the child will respond to trauma and trauma situations. Now, there are things like lower socioeconomic status of the family, parents having a lower education status, parents who are more stressed and with poor coping abilities are the strongest risk factors. And sorry, let's just go back. And then among adolescents, after the September 11 attack, they saw that more media use among the adolescents and their parents were associated with a higher probability of PTSD. So, coming to the second question, what is the most common symptom, do you think, in times of conflict or unrest? So, us as healthcare practitioners, what are we more likely to see? We just give about 15 to 20 seconds, I think, or more if people need it. Right. So yeah, so the results show that 46% of people chose panic, and 48% chose inability to sleep or insomnia. 4% only chose shaking, and 2% chest pain. So yes, people are quite correct. Inability to sleep is the most common symptom. And oh, specifically, insomnia is seen in about 70% of times in people who present with stressors related to war in some regions with, high intensity of conflicts. But we also see, of course, symptoms of anxiety or worry, panic attacks, anhedonia, which is just this inability to feel pleasure in things that one used to feel pleasure doing, sadness, feeling hopeless, substance use, and also, very importantly, people with mental health conditions that were managed well before they can have a worsening or a relapse in their symptoms. So, what can we do, right? Like, what can we do as healthcare practitioners? So, I'm going to be speaking about these 4 points. So, first of all, what's in the patient's control, right? You can't change their gender, you can't change their education level, but there are things that we can work on which make these people have vulnerability factors that they can work on changing. Next, self-help techniques. Thirdly, our communication. What is evidence showing us in terms of our communication, specifically in the Middle East region and in non-Western cultures? How does that affect patients? What can we do to, make their outcomes better just by communicating differently? Excuse me. And then fourthly is referring when you need to. So this is just for thousands of years, dating back to the Stoics and Epictetus as being one of the main figures of the Stoics, it was known, right, that we need to differentiate between what's in our control and what is not. So Epictetus said it really nicely. Happiness and freedom begin with understanding one principle, that some things are within your control and some things are not. And we really need to emphasize this with ourselves, people we know, and also our patients. So this is called the dichotomy of control, again, developed from Epictetus and reading all his writings, which is basically that there are things that are not in our control that we must emphasize, speak about loudly. So the weather, whether a war will happen, the past, the future, what's going to happen with the economy, fine. But these things are there, but they're really not in our control. And then we have things that are in our control. What are we going to do about our life? Uh, are we going to be showing initiative? Are we going to go to work? Or are we going to hide in the house? Uh, what are we going to eat when we have the choice? What kind of food? What kind of activities are we going to be doing? So, and this brings us to the self-help techniques. And these are just basically 10 techniques that we'll briefly go over. And they were developed by the World Health Organization, and they have good evidence in treating mild symptoms or some mild disorders, but also, and specifically among war conflicts, they studied whether in Turkey for the Syrian refugees, whether these self-help techniques can not only, they didn't test whether they can treat, they can see if they can prevent mental illness from occurring. And this was a very nicely done randomized control study. Excuse me. And they randomized people to either self-help with enhanced care as usual, which is basically social support, and the control group only got the social support. And what they found out that in the beginning, because they found they followed these people for about 6 months. Right after the intervention, there wasn't really any difference in terms of the onset of mental illness, whether it changes after receiving those self-help. But very importantly, 6 months down the line, they found that those people uh, in the group that received the self-help, about only 21.7% developed mental illnesses versus 41%, so about double in those, who did not get the self-help and only received social support. In addition to, of course, better quality of life for the group that received the self-help techniques. This is quite, fascinating that it can be even used in the prevention and in the context of wars. Now, firstly, it focuses on knowledge, right? Knowledge helps to normalize stress reaction. It reduces secondary anxiety. So educating people, when you're talking to them or giving them a brochure about normal reactions to stress, can really reduce the stigma and empower them to cope more effectively. If you tell them, you know what, these are normal responses, many people have them. That's different than being diagnosed with a mental illness. If you say that you're sad or you're anxious, it's not the same thing. That helps people. And then, secondly, is routine. And the routine is very important. And, even in this study that was nicely done, it provided an insight into the role the workplace has in the lives of civilians that were exposed to continuing unsafe situations. So during the war, those who worked versus those who stopped working, how did, their negative affect, or basically how they look to others. Do others perceive them as, being stressed or in having a negative mood, or do others perceive them as, in a normal or positive mood? So they saw that actually there was a high uh, association with people um who had their work routines happen normally, and between those people who even had, the threat appraisal of the war high. So they thought that, you know what, the war, it's probably gonna cause us a huge threat, but still, just by going to work, it was associated with less negative affect. Now, what's more interesting, because we spoke earlier about how women are more prone to, developing stress symptoms after conflicts or during conflicts. In this study, they saw that the beneficial effect of work routine and maintaining it during the times of conflict was more beneficial to women than it was to men. And this is what I meant by focusing on the vulnerability factors that one can do something about. Okay. Thirdly is the healthy habits. So, even under restrictive conditions, physical activity supports physical and mental health together. Short exercise routines can be recommended to people, because at times of stress, the normal activities may be uh, unpractical to do. And this can help regulate cortisol, improve mood, and reduce symptoms of post-traumatic stress or other symptoms of mental disorders. Again, this is just showing the summary of studies that showed this positive effect of having a healthy eating habit. So the decrease in unhealthy eating habit with increase in physical activity were negatively correlated with mental health problems, which meant that, continuing to do physical activity, eating less unhealthy foods makes one, there's a loss. Like, obviously, I can't say it's a cause and effect relationship, but at least it's correlated less with mental health problems. Social cohesion. So this is really quite important. They're a strong predictive factor against depression and PTSD. So, what's really interesting about this is that it's not actual social support and getting it uh, that mediates one's mental health and prevents the person from adverse psychological consequences. It's actually just the person's perception of the availability of others as a resource. This is very important because when you're sitting with the patient, it's not about, why don't you call your mother and speak with her more? It's as simple as, who is your support network? Who can you count on? Just by remembering those things and the person perceiving that they have this social support, it really goes a long way. And of course, I can't stress enough mindfulness and spirituality and the role of, religion in people who are religious or encouraging spirituality in patients who are not really religious. And I say that because these can be quite positive, but when given or when recommended to the right type of people. So, we can't make assumptions about people's religiosity or even their readiness for spirituality. Next is, the breathing and relaxation and grounding techniques. Some people find these helpful, others don't find them helpful. But the good thing about them is that they are evidence-based for many people. They're very simple to advise people to do. So I'll show you a couple of them in a bit. And also, even if you don't have time in a busy practice to actually explain them to people, just telling people to look up on Google, certain breathing techniques can help those patients. So one is the 478 breathing technique, which I should be doing more of right now because I'm losing breath. Sorry if I'm speaking too fast, but so 4 seconds breathing in, 7 seconds holding the breath, and then for 8 seconds, 8 slow seconds exhaling. And repeating this 4 times for a few times a day can help. Next is a grounding technique. And what grounding means is that it's basically takes you from all of these thoughts of panic and anxiety to this moment, to the present moment. And a very simple technique that any of us can do or even tell our patients to do is the five senses techniques. So we all have or heard of, the five senses, and we know about them. So we tell them to say out loud to themselves or, really slowly to themselves, even, within their hearts, five things that they can see, four things you can feel, three things you can hear, two that you can smell, and name things that you can taste right now. Okay. Information flow, we spoke about that extensively. You know by now that the evidence for the effect of the amounts of negative media consumption that we can get are really, huge. So managing how much information we allow ourselves, and we recommend our patients as well to manage this type of, the amount of media that they can see. And lastly, among those self-help techniques, so creative expression, journaling, storytelling, these are really nice symbolic outlets for emotions. So oftentimes I hear from patients, they tell me that what helped them from these techniques is when they're stressed, so stressed, especially towards the evenings, that they keep a paper and a pen next to them, and whatever is on their mind, they just jot down. It really helps people that have anxiety towards the sleeping time and that have trouble sleeping at night. And then tailored approaches for specific groups is what it means by that is that, for example, for children, you would recommend storytelling, playing more games. For older adults, social gatherings are quite important and evidence-based to help them. And lastly, digital and mobile tools. And this is more of course, on a policy level, but also if you know or you can look up certain digital tools that you think would be helpful, these can be recommended to patients. So, for example, things that provide guided meditation and these kinds of things. Okay. What else, is there another thing that we can do other than offering this pamphlet or a list of advice to patients? Well, our communication. So, and this is a very nice study that was done where it consisted of a group of experts with over 9 years of experience in treating those affected by the Syrian conflict, so refugees and victims of war, of torture. And what did they learn from all of this experience? What helps and what doesn't help with patients, that are from the Middle East? First, we really need to avoid using professional jargon. You know, professional jargon, psychologically, depression therapy, PTSD, ADHD, we use it amongst ourselves of healthcare practitioners, but it's not really part of the mainstream language that people in the Arab world and certain parts of non-Western world uses. So in the Western world, yes, the colloquial language is consistent. You can see a lot of, oh, I've been diagnosed with this and that, I'm going to therapy, but not so much in people in the Middle East, especially not the younger generation. All right. So what else what instead we can use? Well, universal terms. So for example, suffering, تعب. أنت تعبان، هل حسيت بتعب؟ can be more accepted than you're depressed أو أنت مكتئب أو هل شعرت باكتئاب. And finally, among the communication, things which are associated with worse outcomes, one is assertiveness, acting like you know it all, and that patients should do what you recommend. And by know it all, I mean like claiming expertise, or being a person that likes to predict outcomes. So yes, we're speaking now about things which are more likely to happen if you do this or you don't do that, but it's not the same as telling a person, if you don't, go and exercise, this will develop to you. Yeah, this is less likely to create a therapeutic relationship where the patient actually listens to what you are giving in terms of advice. Okay. So since this conflict has started, people have been asking a lot about how to support their kids' well-being. So this is why I wanted to conclude with these evidence-based points that are specifically found for children. Okay, so research in the Middle East especially found that parents act as one of the largest protective factors for children during the war. So remember we spoke about how parents can be a factor in causing mental illness, but here it says even in protecting from mental illness. So continuing routines and daily activities and school. Of course, we can't control if the schools are shut down, but we can control to have the kids wake up at the same time that they usually wake up into, and attend the online class at the same time, have their breaks at the same time. They can't play with other kids in the playground like they did in the school, but we can help them create games during their breaks. In essence, just continuing the routine, whatever they used to do, we continue it. Then positive parenting also decreased risk. So so instead of hitting the child, when they do something wrong, warning them using methods of grounding, instead of shutting off conversations, listening to their concerns, and this is very important. Kids over this period have a lot of questions, and I'm sure, those of you that interact with kids can relate. They ask a lot, they want to speak a lot. And so just giving them this time is shown to prevent negative mental health outcomes. And then finally, really managing the parents' mental health problems. So if you feel as a parent or a caregiver of a child that you are suffering from certain symptoms, things you're not able to function well at home or at work, this can affect not only you, but others around you. So it's very important for you to really seek assessment, seek proper diagnosis and treatment, and it will benefit you and also benefit your kids naturally. Okay, just to summarize the take-home messages. So we've seen that obviously conflicts are not homogeneous. So in one place you can find direct combat and torture, and in other places simply the fear of the conflict coming near them. So their effects naturally vary. But in addition, each individual has individual responses that they are more prone to. And of course, while there is much that we still don't know, we still figured out about vulnerability and protective factors. And again, when we think about vulnerability factors, it's important to think about what we cannot control versus what we can. We cannot change our age. We cannot change whether we have a previous psychiatric history, but we can do certain things like stick to routines, consume less news, engage socially. Uh, Very importantly for healthcare practitioners, normalize stress symptoms. These are a normal reaction to conflicts. You can say things along those lines. Offering self-help techniques and even to prevent, and effective communication skills. Like we said, less psychologic and scientific jargon, effective listening, asking rather than assuming. I can't, tell you how many times I've seen a patient and I've thought, this patient looks religious or I don't know what. But then just by asking, my assumption proved wrong. And if I didn't ask, but assumed when I gave them the tip, it wouldn't have clicked. And lastly is, of course, for people who have persistent symptoms or for people who have symptoms that may endanger their lives or the lives of others around them, always refer to the specialists. This is just a list of references. I'll be sharing the slides later on, so you can review if you want. Well, there it is. I'm glad you are here. And the reason is that by being here, you've demonstrated that you have a great understanding of the importance of learning about the effects of conflicts and that you are keen about protecting others around you. So thank you very much.